Good afternoon, everyone, and welcome to this webinar. It's a delight to be here with you. I would say we could paraphrase the title of this webinar is something like "May you live in interesting times," because the topics that we're going to cover have been some things that really have been the most extraordinary changes in many of our lifetimes. The impact of a pandemic, and secondly, the impacts of air pollution on people's lives. All these in the context of COP26 coming up, with the threats to our lives and nature that we're all too familiar with. So I hope you enjoy the session. We're divided into two parts. The first, we're talking about the impacts of COVID, particularly on respiratory health. And in the second session, we'll be focusing on air pollution and health impacts. In the second session, we're delighted to be joined by Professor Jim Gauderman, who will be joining us to give a keynote lecture from California. And my phone tells me that it's 6:42 in California, so we're especially grateful for Jim to be up early and giving us the benefit of his expertise. So if you have questions, then please put them in the Q&A panel rather than the chat, and feel free to leave any comments in the chat. So I'm going to hand over to our chair for the next session, which is Monica Fletcher. So thanks, Mon.
Lovely, thank you, Chris. Yes, Chris said, welcome, and the afternoon is divided into two parts. And the first part is actually the impact of COVID-19 lockdown. And it's funny because we've had the slide earlier, we talked about lockdowns, and of course we are talking about lockdowns as it actually happens, but and really what the impact had on people with asthma. And if you recall, when the pandemic actually first hit, people with asthma and other respiratory diseases were extremely concerned, as was the respiratory community, about what was going to happen to patients who were perhaps more susceptible because they had respiratory conditions. I am really looking forward to this discussion this afternoon, because what we're going to share with you is what we found out actually. A couple of really what I would say seminal papers have been published about the impact. And then we're going to have an open discussion with a really interesting panel about, we can hypothesize as to what we can learn from what happened for the future of pandemics, so that we could perhaps be more prepared, but also about general asthma care and respiratory care. So we're going to kick off first of all with an interesting couple of papers, which I think Professor Gwyn Davies is now going to share with you. So oh, no, first of all, I've got the panel. So this is going to be our panel, but Gwyn is going to talk first, and then Dr. Tracy Jackson will be talking about another perspective, which is what patients actually felt about during the pandemic. But first of all, Gwyn, I'm going to invite you to present those two papers particularly, and then what we would do is invite you as an audience to actually postulate as to why that might have happened, and then we're going to open it up to a panel discussion. So over to you, Gwyn.
Thanks, Mon. Slides, please. Thank you. So I'm going to talk about what happened to asthma attacks in the UK during the lockdown. And I'm going to focus on two studies which looked at this. By way of background, one of the unknowns at the start of the pandemic was how SARS-CoV-2 would affect people with asthma. It was feared that it could lead to a surge in exacerbations because viruses are one of the commonest causes for these. Slide, please. So two studies in the UK looked specifically at what happened to asthma attacks, and both were published in the same edition of Thorax. Both the studies used similar interrupted time series methodology. Because asthma exacerbation rates change over time, it's important to compare with previous years and also to compare pre and post lockdown periods. Slide, please. So the first study, next slide, thank you. The first study was the one I was involved in with colleagues in Scotland and the EVE2 collaborators. So we focused on severe asthma exacerbations resulting in hospital admissions in Scotland and Wales. So in red, you can see the data for 2020, and in blue, we see the averages for the previous 5 years. The dotted line represents when the pandemic was declared globally, and then the solid black vertical line is when the first UK national lockdown was announced on March 23rd. So what you can see is a dramatic drop in severe asthma attacks, in severe exacerbations requiring hospital admission in both countries at lockdown, and then sustained in the lockdown period. There are similar patterns for both countries, but some of you will spot a small difference, which is in Scotland, the exacerbation rates had started to pick up again by the end of the 18-week study period, but in Wales they were continuing to fall. So we saw a pooled reduction of 36% in severe asthma exacerbations resulting in hospital admission. Now we also wanted to look at asthma deaths because there was concern that people with severe attacks might be trying to ride out these at home due to fear of COVID. But reassuringly, we saw no corresponding increase in asthma deaths during this period. Next slide, please. The other study was by Shah and colleagues in England, and here they focused on primary care-based exacerbations. So presumably a milder exacerbation group here. So again, we're seeing the dotted red vertical line is when lockdown was imposed. And we can see in purple, we can see a substantial drop at and just after lockdown in these primary care recorded exacerbations. Slide. And this represents almost a drop of 20 episodes per 100 people with asthma per year. So a substantial reduction was seen for both sexes, all ages, and across most regions in England. So in summary here, we're seeing the largest drop in asthma attacks that's ever been recorded in the UK, both in severe exacerbations and in primary care reported exacerbations. The big question now is, what are the reasons behind this? And how can we learn from them to drive down exacerbations longer term? Thank you.
Thank you, Gwyn. If you pop the slide up again for me, please. And the next one. Because what we want to do now, and it's very difficult for Gwyn to present this without actually coming up with some of those responses, and because I'm sure that she's been thinking for some time about what might cause this, is that we're going to ask you to actually have a consideration before we move to our panel. So I'm going to ask you, please, if you could possibly go on to Menti. I don't know, some of you may have used this before, but Mentimeter is a very good way of actually being able to get your views. So whilst I'm talking, if you can either click on the link that's down there, or you can go onto your phone or your browser, and you will have to put in the code that's on there. So that is 63713257. I've said that rather fast, but you can see it, we'll keep it on there for you. So that's 63713257. So I'm just awaiting you to try and find your way either to link on or to use your phone so that you can go onto there. And what we're going to ask you to do is that, given the evidence that Gwyn just gave us, that there were fewer asthma attacks in the UK during the COVID-19 lockdown, we'd like you to postulate from your perspective as to why you think that might have happened. We'd also like you just to consider two of those answers, please. I'm sure some of you might think it's a mixture of all of them, but I want you to take it from your perspective as to why you might think that is the case. So the options we've actually given you there is environmental causes, because people were staying at home, they weren't going out and about, the fewer viruses, which Gwyn mentioned earlier, adherence, was it about self-management, that patients were actually managing themselves at home, so they were perhaps doing that better than we might have expected? Was it that they didn't want to go and see doctors, so they were at home and maybe were having symptoms but weren't visiting because they were afraid of going to see either a hospital or a GP, or was it for some other reason? So I hope that amongst you out there that we've got enough of you that are actually able to access Menti. Hopefully I've given you enough time. If you're having problems, if you could put something in the Q&A rather than anywhere else telling me that you're having a few problems, but if you're not, it would be good to get some kind of perspective. We're not going to throw this up straight away, so we'll give you a little opportunity, because I'm going to invite our next speaker, but then we will come back to this poll to find out what you thought, perhaps the key reasons. And this is going to form the basis of our discussion with our panel. But for now, what I'd like to do is to introduce our second speaker, who's just going to really look at this from the patient's perspective. And I'm delighted to say that we've got Tracy here, who's presenting on behalf of a wide team, and some of you are actually in the audience here today, about what was the psychological impact of COVID-19 pandemic on adults with asthma. So Tracy, the floor is yours. We could put Tracy over to speak. That would be fantastic.
Thanks, Mon. So yeah, as you said, I am part of a wider team. So they're listed here, and it's just to highlight that Noelle is one of our patient and public involvement members, and she worked with us on this study as well. This is a mixed method study we did last year looking at the psychological impact of COVID, and this is the qualitative results I'm going to present. Next slide, please. So a little bit of background, although I think we probably all know this already. March 2020, COVID was declared a pandemic, and in the UK, the term shielding came about, and this included people with severe asthma, who were asked to shield, as I said, in the UK. And at the start, there were a lot of changing thresholds as we learned more about COVID, and so there were some unclear messages, and it led to uncertainty for some people with asthma about whether to shield or not. Next slide, please. Thanks. And so this is a timeline of what will happen. And the reason I put up this slide is, and if you hit next again, please, it'll show when we did the interviews. So we did them in the 13th. So the 13th of May was when lockdown began to ease in the UK. And so we did the interviews between the 22nd of May last year and the 12th of June last year. And this was after lockdown began to ease, but before the shielding guidance eased. Next slide, please. And next again. And next again. Sorry, I should have set these up a little bit better. So we were looking at the experiences of people with asthma during the pandemic, and we spoke to 26 people, 15 female, 11 male, from across the UK, as you can see by the diagram on the right. 15 people were shielding, 11 were distancing, and we had a really wide range of people. So from people between 18 to 25 to over 65. We recorded all the interviews, transcribed them verbatim, and analysed them thematically. Next slide, please. So we had 5 themes. Here they are here, and I'll go into each of them in more depth. The next slide, please. And it'll be the first one, which is health communications. And so health communications was looking at the messages that people were receiving about COVID and about their asthma during the pandemic, and online social media, so it covered that. So you can see on the top quote there, someone saying about how they used to listen to the daily briefings all the time, but then started to avoid it like the plague, because it just became too much, too overwhelming. And at the bottom, someone's talking about the delivery of the messages. They find them actually quite confusing, and that in itself was causing anxiety for them. Next slide, please. And so the next one here is the interaction with healthcare. So this is contact with healthcare that participants had, and also remote consultations. So at the top, someone was talking about how they'd been proactively contacted by their GP, making sure they were okay. So there were quite a few of these, but with this person, they said that they found it quite shocking that they'd been asked whether or not they wanted to be resuscitated. They understood afterwards why they'd been asked, but they felt the way in which this topic had been approached with them was a little bit upsetting, a bit shocking. And at the bottom quote, we can see here, someone's talking about these remote consultations, everything being online because they weren't allowed to the GP practices. And they actually were very positive about them. And this is, a lot of people that we spoke to said this, they found them more liberating, and there were a lot of benefits. They found them a lot more convenient. And so they were very positive about them, but with the caveats that they preferred it if it was someone they knew who was doing the remote consultation with them, someone who knew them, who knew their asthma, and they didn't think it worked well with certain things such as checking inhaler technique. Next slide, please. And so the impact on mental health was really big, was quite everyone who spoke to us, their mental health had been impacted. So the top here we can see how people were really trying to use coping strategies, so going for a walk. People talked about getting into routines and sticking to them, and just trying to, as you can see, someone's saying here, keep their spirits up. People were talking a lot about losing control and about the grief that they were feeling. A lot of people talked about death, creating wills, and this person here is talking about how they felt they were grieving for time lost in their life while they were just sort of stuck inside during the lockdown. Next slide, please. So yeah, the top slide here, people were talking a lot about adapting to a new normal, how that impacted them. So the first one here is saying that they just, after about the 3rd or 4th week of lockdown, that they just didn't really want to do anything, and they could have slept all day. And then at the bottom, and I think this goes back to what Gwyn is talking about earlier, where she said that this person's saying about how actually the lockdown had a really positive impact on their asthma. They hadn't really changed their asthma management at all, but they'd noticed that their symptoms, they weren't having as many symptoms, and that their asthma was much better controlled. Next slide, please. And this is our final theme, and this is about COVID-19. So top one here, someone, and this came across a lot, someone talking about how they felt that if they left, if they went outside, that they were just going to die because they were going to catch COVID, and that's how severely that they would be impacted by it. And at the bottom is something that a lot of people told us, because people with asthma often have a cough, they have their asthma cough. And so people were very confused about what signs to be looking for, what was the difference between an asthma cough and a COVID cough. And so they were really just relying on their own knowledge of their asthma in order to help them figure out whether it was asthma or whether it was COVID and it needed to be taken much more seriously. So, and on to the final slide, please. Yep, so people with asthma experience confusion, fear, anxiety, and a lot of people mentioned being very lonely during the pandemic. This is the first lockdown we're talking about. They described a lack of control, living in an uncertain environment, and grieving for time lost. And implications for this would be clearer guidelines and support from the government and healthcare providers may reduce the psychological stress in people with respiratory conditions in future pandemics. And that's all of my slides. Thank you.
Lovely, thank you very much, Tracy. And we'll come on to some of those points you raised in the discussion. So I think we are now in a position, if the technology's worked well, thank you, Claire, to actually see what you thought of the priorities in here as such as to the causes. So we have environment featuring very high there, fewer viruses circulating, adherence, improved self-management, reluctance to seek help, and well, that's the combination. We're going to pick up all of these points, and please put questions as we go along into the box. And I'm going to open up now to our panel. So hopefully we can get everybody onto the screen now together, and we're going to have a panel discussion to explore some of these, what you've said, but also what the panel's view might be. So if we can just move into that format, we should hopefully suddenly see our whole panel. I think what I would do is actually ask our panelists to introduce themselves. I think most of you will know these people, but as they first speak, it'd be fantastic if people could introduce themselves. And if you could come off of, your closed screen, so open up your cameras, that would be fantastic. Lovely. And have we got Aziz on the panel? Yeah, Aziz. So, because first of all, I'm going to ask actually our two panelists who were involved in these two publications. And Aziz, I know you were on both of those. Gwyn has said this was the largest drop in asthma attacks that's ever been seen. Were either of you surprised by the results of your work? And from your perspective and your author's perspective, what did you think were the key issues that you could put down as some of the causation of these findings? So perhaps Gwyn first, because you've presented, let's bring you back in.
Thanks, Mon. I was surprised by the magnitude of the drop. So 36% reduction in severe exacerbations across Scotland and Wales. That's huge, isn't it? So I was surprised how large it was. So I think the main explanation is reduced transmission of other viruses other than COVID due to lockdown and the hygiene measures and so on. But it was, I didn't foresee that it would have that huge an impact. I think other important things, and I've got a slide later on suggesting improved self-management. So we did see in Wales a huge spike in the week pre-lockdown in inhaled steroids and oral steroids. So those are spikes of 120% and 130%. So huge spikes. That's a really important piece of data for me, in that it's really showing how patients were very active in realizing that there was a lockdown coming and not being sure what that would mean in terms of their healthcare, as Tracy's alluded to, and really being very engaged in getting their inhaled steroids and getting their rescue steroids as well to keep them out of hospital. So I think improved self-management is a really important part of this as well. Lastly, I would say improved air quality.
Okay, good. And this is really interesting, because this obviously, now, is this prescribing data as in scripts? Is it dispensed? Do we know what actually happens afterwards? Can you just explain?
Sure, it's GP prescriptions in Wales. So it's showing that, not only are the patients being very active in seeking out these prescriptions, obviously the GPs are being very active in prescribing them as well. I believe this was happening across secondary care on a big scale as well. As a hospital consultant, I know I was posting out oral steroid prescriptions in bulk to my severe asthma patients. So I'm sure that was happening across the board. And it's never something, I would do in ordinary times, of course, but none of us really knew what was going to happen to the health service. We were seeing terrible images from Italy at this time. So I think, it really highlights how engaged patients were, and how they, perceived that their medications were the most important things they had, and they perceived that the importance of those was much higher than perhaps it normally was.
Okay, thank you. I'm going to invite Aziz also to make a top line comment. I'm sure Hilary, and I'm going to ask David in a moment also from a patient's perspective, and I'm sure Hilary will have some views on the self-management and whether that was followed through. But Aziz, what's your top line thinking?
Yeah, so very similar to Gwyn's. We were expecting a reduction, and that's why we set up the studies. But I mean, the magnitude did surprise me. I mean, I think one of the strengths of what we were able to do was do basically exactly the same study across 2 national data sets. One of the first times I think that's ever been done. In terms of sort of what's driving this, well, I mean, I think it's likely to be multifactorial, as is so often the case. But for me, the kind of big ones are reduced exposure to viruses and other sort of environmental triggers. Because I mean, I know during, I mean, as somebody with asthma, I mean, I often triggered by viruses myself. I had basically no exposure to viruses myself last year.
Okay, thank you. Should come back to that one in a moment. David, as a patient, I'd love to know how it felt for you at this time, and were you one of the patients that went out to get your prescriptions? How does this resonate with yourself?
Excuse me, I was shielding, so I wasn't able to go out at all. So I was very impressed by the slides that were put together by Tracy. They did follow very much in parallel with my experience, and certainly there were a huge range of concerns that I had. The concerns lay in things like day to day we were getting news from the TV and newspapers. It was almost like doom, you know, like, I don't know whether you ever watched Dad's Army, you're probably too young for that, but at that time, Private Fraser used to say, "We're all doomed."
We're doomed.
Doomed. We felt very much like that. I certainly did. I had a concern over actually getting access to prescriptions at all. Contacting the GP was proving extremely difficult. I had an inability to get through GPs, I couldn't go out for a walk, I couldn't go swimming like I usually do. So the whole thing was total loss of freedom. And that was my major concern. Is there a future? And I felt at one point, is there going to be a time when we get out of this? And obviously the results associated with the vaccines and the discovery of vaccines just brought my life back into some kind of normality. So that's where I'm coming from.
And I'm sure for many other people like yourself, David, too, but or Captain or Pike, I was going to say, but you remember it well, unfortunately. I'm going to bring in Hilary now, because there's been quite a few comments there about self-management, patients' behaviours. I wonder if you'd like to make any comments or observations from your perspective, Hilary.
Yeah, I absolutely saw this from the prescribing end. As Gwyn was saying, I mean, we were prescribing, particularly inhaled steroids. I mean, you know, people are always asking for their blue inhalers, but I don't think I'd ever been asked for quite so many steroid inhalers. You know, every time we were doing our list of prescribing, there was steroid inhalers being requested, and some steroid courses, oral steroid, but particularly the inhalers, and indeed I believe the supply chain on the one of the common brands of steroid inhalers actually ran out. So it wasn't just us prescribing them, people were actually getting them from the pharmacist. Now clearly I don't know what they were doing, whether people were actually taking them or not. It was like that we were actually stockpiling loo rolls as well, weren't we, at the same time? Who knows whatever we did with those. So, you know, there was certainly a stockpiling of preventer medication. Did this improve self-management? It certainly, I'm sure, was it was a contributory factor. Has it been maintained? Because that's really what interests me going forward. I mean, I saw it happen in a panic situation. I would like to think it could be maintained, and one of the things I think I'd like to think about going forwards is how we can build on the experience that people with asthma had when they suddenly realised that actually it'd be a good idea to start some preventer medication. Can we build on that to try and take this forward with self-management? Self-management, of course, isn't just about taking in prescriptions. It is around knowing when to contact help, how to contact help, how to avoid your triggers. So a lot of the issues on that, I would say, are all part of self-management on the Mentimeter.
Absolutely. I just wonder, Hilary, though, as time's gone by now, are you seeing patients not asking for repeat prescriptions so often? I mean, that one might give you an indication.
It's settled back down.
Yeah.
I think it's settled back down. I have no reason to think, certainly some figures that we've just generated for Impart do suggest that things have actually, it was a spike that went down. But maybe we can build on that spike to change a few people's perceptions.
Lovely, thank you. Stanley's asked a question about children, and that gives me an opportunity to perhaps bring in Andy. And I know that these studies they were with adults, weren't they, Aziz? And I think you looked at adults just Aziz, I think was the case with your papers. But Stanley's asking, were there any specific observations about children? Andy, the opportunity to come in now. Andy Bush, where are you?
I'm here, thanks. Thanks, Mon. I'm Andy Bush from Imperial College in the Royal Brompton. A question about inhalers and the like. The patients we see are obviously highly selected, but when the electronic data that we had, limited amounts, showed absolutely no difference in the pandemic. Now, that's a very small study and a very limited, in a very specialized group, but I think we should be careful about jumping to conclusions, as Hilary was very careful. Up doesn't actually mean anything useful has been done with it. And I suppose in the clinic, I would say that if there was a surge of enthusiasm for self-management, I'd expect an initial drop in attacks, but then to start to creep up during the pandemic as people lost momentum as frequently happened. So I'm skeptical about improved self-management. I may be quite wrong, and I don't have data. In terms of Stan's question, as I'm sure Stan, Stan, across the world, it's all the data on all ages, all degrees of severity of asthma attacks. What as you said, as people said, the concerns were people not going to the doctors, but actually all levels of asthma attacks dropped all over the world, and I don't think that was a factor.
Chris, we've heard the environment mentioned. I wanted an opportunity to bring you in here. I wonder what you would like to comment on environmental factors and also from your GP perspective about some of the things been discussed already.
Yeah, thanks, Ron. I mean, a number of comments. I heard David said that he just couldn't contact his general practitioner. And I wonder, well, I know from my experience as a GP that essentially we shut our doors, and to a large extent they're not very wide open even now. So I think people experiencing an asthma attack probably would have found the same, difficult to get to speak to the GP, impossible to get to see the GP or the practice nurse. And I was wondering if Tracy had any qualitative data on how people were managing asthma attacks. You know, it's not a dichotomized state. You know, you're either well or you're in status asthmaticus, as we used to call it. You know, there's a huge spectrum there. And to what extent are people just not sitting on their hands, but just trying to deal with it as best they can, because they don't want to go to hospital because there's a risk of picking up coronavirus, probably even higher there, and they can't get to the GP, and the 111 service is overwhelmed with other people. So I don't know whether we don't, as far as I can see, have any evidence on how people were managing asthma attacks, severe, mild, moderate, and that could have an important influence or important explanatory effect on the for the data that we see. We just don't know, and so I suspect the combination of GPs shutting doors, although we were on the phone and so forth, could have had a very big effect.
Could I have an opportunity there for Tracy just to respond to that, Chris, before you move on to the second point? So Tracy, did you have a comment? Was that anything that you can pick up from what Chris just said? Or?
Yeah, great question, Chris. So really no one really talked about specifically asthma attacks or how they were managed them, specifically about exacerbations. People did talk proactively about taking more exercise or eating better, or really making sure that they were a little bit more on top of their management. Most people we talked to said that they did really manage their asthma well, but maybe just a little bit better during the pandemic. I do know that a few people mentioned that about going to the hospital. Some people were a little bit scared of that, but a lot of people really enjoyed, or not enjoyed, but really benefited from the virtual and remote consultations. They felt that they fitted in better to their lives. They felt safer with them because they didn't have to go to the practice where they might catch something, or they didn't have to sit in a waiting room for a long time. Some people even talked about emails or texts from their GPs. They really liked that interaction.
Chris, I'm going to come back to you. There's a hand with Andy. Is that a legacy hand or is it a new hand?
It's a real hand. I just wanted to say, as a non-GP, watching how, led by our glorious Secretary of State for Health, bashing the GP seems to be the flavour of the month. From my observation, and this is just a very small sample, my elderly relatives got a great service. They were triaged by phone. If they needed to see somebody, that could happen. But to bring a 99-year-old up even a mile away to a surgery is not a trivial exercise in those times. And I think actually the mix and the telephone follow-ups that she got, she's very fit, she didn't have many problems, but the telephone follow-ups, just somebody checking with her, is everything going smoothly? Are we going something, were actually extremely valuable. And I'm sure one of the things I know that you, Hilary, and many others are thinking about are how going forward you can get the best out of what you've had to learn quickly from COVID. Identify the decisions that actually, with retrospect, were not right, but we had to make a lot of them fast, and take forward the things that went well. So I just
have to say, I don't want to imply that GPs were doing nothing.
Certainly we're not.
No, nor was I was saying.
We are absolutely overwhelmed with consultation demand and request at the moment. And I go to surgery, I sit down, and 12 hours later, I get up again and go home. And I'm absolutely exhausted because the demand is huge. It's my point was about getting advice from a GP or being physically assessed. So don't take my comments out of that context.
I'm going to just bring back in another GP, and then I'm coming back to you.
Yeah, it's a fairly
with Aziz. So Hilary.
Yeah, it's a quick point, really, Monica. It was just that there was talk about, the fall in attacks. I just wanted to raise a coding issue here. We changed our coding. As because typically when we see people by telephone, we often call it a telephone consultation rather than make a diagnostic code. And during the course of the pandemic, we switched over to telephone consultation in the course of a pandemic or some such code, which of course means that finding an acute asthma attack that we did speak to would not have been very easy for people using our data. So there is, I'm not saying that that's the explanation, of course. I'm sure there was a real drop, but I suspect that will have made it difficult to detect consultations about acute attacks that we had remotely.
Obviously within primary care setting, but obviously within the secondary care setting.
Of course, exactly. So it's only just a factor.
No, lovely, thank you. I'm just going to, before I come back to you, Chris, I want to bring Aziz back in, because Aziz's got some quite, I think, sensible and strong opinions about bringing patients down to surgery who are having an asthma attack outside the pandemic. Aziz, I know that you have some great thoughts about this.
Yeah, so I think a few points. One is, Dan, this is looking at all ages, so it's looking at kids and adults, and where we did analysis sort of age stratified, we're also seeing similar signals in kids. So this is being seen in the round. And I think we were sort of concerned, and reviewers raised this as well, around how much of this is some kind of coding artifact. Is there displacement going on? What we were able to do is in Wales, because A&E data or ED data are also coded, unlike in Scotland, and we were able to see a reduction in asthma exacerbations presenting asthma attacks presenting to A&E. There were concerns also raised about reviewers, about some of these people dying at home, so we did that analysis as well. And certainly there was no evidence of increased asthma deaths, possibly, a suggestion of, a reduction in asthma deaths, but that wasn't statistically significant from memory. So, I think in the round, all of these things were pointing in the same direction.
Sure.
I think where we need to get to is what are the kind of transferable lessons, because clearly we can't sort of impose lockdowns. I think one of the things that we do need to be thinking about is how do we organise care, because at the moment, or sort of historically, what we've been doing is in waiting rooms, whether that's in outpatients or in GP surgeries or wherever else, mixing of those with infectious disorders, and these are the commonest triggers, with those with chronic disorders. And actually, Gwyn also led an analysis in COPD, seeing very similar patterns in reductions in COPD exacerbations. So that mixing, I think we need to find a way of trying to avoid that. I think we had normalized, if you've got a cold or whatever, some respiratory tract infection, that you pitch up for work, you have a stiff upper lip. I think that can't be right going forward. I think we just need to really begin to distill what these transferable lessons are for peace times, hopefully, once we're there. Thanks.
Thanks, Aziz. Now back to Chris and the environment. We never really got to that point, but Gary McDonald, who's known to many of us, has posted something, and he said the EAD data showed no overall improvement in air quality during COVID. Would you like, was there any comment you'd like to make about that?
Well, my understanding that in London, NO2 levels fell, that ozone levels rose, PM 2.5 was stable and increased for a bit after lockdown. So there were changes. Some pollutants went down and some went up. So it was a complex picture. We know that NO2 NOx triggers asthma attacks. There's a presentation by my colleague Hajar coming up shortly that looks at this, which you may find of interest. But I think improvements in air quality, when there were dramatic falls in traffic volumes, which were also monitored, you monitor them through Google and so forth. These were dramatic, and they will have had a contribution. And there are some air quality epidemiological studies suggesting, a relationship between air quality and coronavirus transmission. So I think it's certainly a factor. I think what we're having difficulty is attributing, to what degree one factor is impacting on the observations that we've seen in the papers. So I would say air quality has had an effect. People may not have been out in the fresh air to experience the improvements so much.
Absolutely. But surely it's the same as, I think, again, that report said it was an initial, a bit like the prescribing. Initially there was quite a dramatic change, but latterly that tailored off. But I think what you're saying is far more of a complex, and this individual's exposure as well, isn't it? Is quite, that's something that's we struggle with, collecting an individual's exposure, both indoor and outdoor air quality. Okay, Aziz, you've got your hands up, and then I'm going to give you all a little opportunity to say, what could we do differently? From your own perspective, just one point that you could make. What do you think we've learned, or what do you think we could do differently? Hand up first to you.
Yeah, so maybe one just before that. I think this issue about personal sort of exposures, it is a really important sort of consideration, because I know, we as a family found walks that we didn't know existed, and so we were all looking for green spaces, etc. And so it's been quite a revelation in that respect.
So let's go, David. I wonder if you would like to make a suggestion, or about what have we learned? What did you learn as a patient? What messages could we take from you?
I think the primary concern that I had initially was associated with the fact of isolation and the provision of information which wasn't national. And we don't have a national health service anymore. We've got a Wales, we've got Scotland, we've got Northern Ireland, etc., etc. I'm not sure that's a significant improvement in the way forward. I would like to see, I think that what's happened here is that the fact that people have been isolated one from the other has contributed significantly to the drop that we've been discussing just now as a major factor. I still wouldn't like to see lockdown happen again, but I would like to see something of that form take place, where we were moving towards another rise in the levels associated with COVID or any other disease of this type. That's about it.
Thanks, David. I think that's something you're saying something very, very clear there, that that we're a whole, and looking at individuals as a whole, the isolation actually and the impact of isolation on somebody's health as a whole is an important consideration. And maybe in future we need to be thinking and considering that as a health service far more seriously than we did. Thank you. Andy?
So I think what we've learnt from in hospitals, I know in GP it's different because we've been doing it for much more for years. We've learnt actually that an enormous fillip to telemedicine, that yes, of course you need face-to-face appointments. And in my practice, anybody who wants a face-to-face can now have one. But a lot of people find that the telemedicine approach is actually very efficient and economical and saves traveling. You can plan tests virtually, get the child up, see the child, do the test, do everything in one go, and then discuss the tests by video link, one trip up to the hospital instead of 3. And I think we've been slow to learn from primary care that you can actually do a lot very effectively, at least as effectively, if not more so, whatever the Daily Mail may say, by doing it remotely. And I think we've got to build on that.
Thanks. Thank you so much, Andy. And I think I might just bring Hilary on.
Yep, I completely agree, Andy. I jotted down when you were going to ask that question. Part of it was about remote consulting. 20 years ago, I published a paper that showed that you could reach more people with telephone asthma reviews than if you invited them in. It's taken us 20 years and a pandemic to realise that actually might be true. Clearly, COVID pushed that balance far too far the other way. We had to social distancing, but now we have an opportunity to bring that pendulum back to a sensible midpoint where there is a combination of choice as well as necessity in terms of conditions and severity and things. So I think that would be my first point, but of course I'm going to say self-management as well, because as I would see it, the whole point about being able to see people, being able to talk to people, reviews is in many ways is around supporting people to look after their condition, to support self-management. So I see it as a means towards supporting people looking after themselves.
Thanks, Hilary. I'm going to move over to Gwyn.
Could I quick come back?
Oh yes, so sorry.
No. The one problem we have not solved, and that is child safeguarding, which has been was a disaster in the pandemic. You just had to say I'm safe, I'm shielding because I've got COVID. It's game, set and match the social, but nobody can get
yes, it. Yeah, very important point.
Really and I don't know how.
Very important point. Gwyneth.
I'd focus on reducing viral transmission. So in hospitals, I think we're really poor at infection control despite best efforts. Everyone's mixing together in A&E and so on. So that really needs to be a priority. And in non-healthcare settings, across the board, I do think there needs to be a conversation and a cultural shift potentially to really look at protecting our most vulnerable people in our society. And I think on a personal level, people in those vulnerable groups need to consider what level of risk they're willing to put up with, because obviously well-being and mixing needs to be balanced against reducing viruses. But I think sensible precautions would go a long way.
Lovely, thank you. Tracy, do you have a final word?
Yeah, thanks. I my takeaway from this is there needs to be better health communication for better mental health for people. I think there was a real bombardment of information, a real infodemic, and it's finding that balance between motivating people to make better health choices versus terrifying them into doing something. One of the people we spoke to in our interviews hadn't seen their wife for months, even though they shared the same house with them, because they were meant to be shielding. And that's not good for anyone to be doing things like that.
No, and I think very much you're picking up the point that David made at the beginning. So thank you for that, Tracy. And finally, Aziz, you've learned that there are lots of lovely green places to go walking. But I wonder if you'd like to make a final comment, because we're just about to sum up now. So
Can I say something?
Oh yes, of course. Come back.
You're going to leave me out, Micah?
You slipped off my screen, so yeah.
That's all right. Aziz can speak in a second, but I agree with everything that people have said. Reducing viral transmission. I think one of the things that we should take away, let's get the air quality message, is the outdoor streets are massively improved for a lack of road traffic. So let's remember the benefit that everybody enjoyed from a lack of cars pounding up and down our streets.
Thank you very much, Chris. And finally, Aziz.
Yes, I too agree, and just on that front, I remember, I was, with the lack of noise pollution, hearing birdsong that I'd never heard before, so it was absolutely fantastic in that respect. I think maybe sort of one sort of complementary point is that, I think we've just been able to see that the power of data that we're able to generate for COVID, and if only we had that kind of real-time intelligence for asthma, other respiratory conditions, where might we be able to get to? So I think that, there's kind of another important transferable lessons that we need to try and learn, I think.
Lovely, thank you. And for somebody who lives about 10 miles from Gatwick, I can tell you we had a huge difference as well from, and suddenly now my dog thinks that every aircraft going over is a bird. So we have barking now more than ever before. So I think, thank you everybody for my panel. Thank you all for listening. We've learned some great insights here. Thank you for Gwyn for stimulating the whole discussion and the work that you and Aziz and colleagues have done. I think we could write a really fantastic summary for some of these discussions, which I hope we will do. So that's the end of this session. We are about to have a break and we're going to move into Chris's session. But before we do that, I'm going to give you an opportunity to obviously go and get yourself a cup of tea, have a little comfort break. But we also, leading into this session, I'd like to share with you a piece of work with my hat on now as the advocacy lead for the centre. Obviously, we with our work in advocacy, it's about actually raising awareness from the work of the centre. You all are well aware, and by the next session you'll be even more aware about COP being starting this weekend, COP26. And as a centre, we have produced a piece of work which features Chris, but it's really to raise awareness about the effects of air pollution, effects on health. So you're welcome to watch this video. It lasts for about 3.5 minutes. So if you can multi-skill, get yourself a cup of tea as well. We'll be meeting back in about 5 minutes. So thank you. So Claire will play this, and we'll see you all in a little bit. Thank you very much for listening.
So Chris, you head up the UK's largest respiratory centre. You've got a body of over 100 scientists spanning across all 4 nations in the UK, and you're backed by the charity Asthma UK. So I'm assuming you're going to be hoping that air quality is on the agenda for COP26, but do you actually think it will be?
Well, it's billed as a climate conference, and the focus is on obviously net zero for greenhouse gases by mid-century. Air quality is just regarded as a kind of secondary byproduct of other matters, and health is barely mentioned at all. Look, if you're a person with asthma, air quality matters now, not mid-century.
And given your background in this kind of research, could you spell out to me the kind of everyday life impacts that poor air quality has on people like myself? I suffer from asthma, or other respiratory illnesses.
Well, a good way of putting it really is as a double whammy, because air pollution causes lung disease, asthma, COPD, chronic bronchitis, but it also makes those conditions worse and makes them deteriorate over time. So, for example, with COPD, obstructive pulmonary disease, your lung function declines over time directly as a result of impacts of air pollution, and you die an earlier death. So we know globally that traffic-related pollution causes 4 million cases of childhood asthma a year. 7 million people die related to air pollution.
And why do you think, Chris, in terms of COP26, air quality and the effects that climate change have on human health is being treated as a kind of secondary issue?
Air quality seems to be secondary to decarbonisation. Decarbonisation is obviously terribly important, less reliance on fossil fuels. Why is health lacking in focus? I think it's just regarded as, if you do one thing, the other thing will happen.
Do you think that the UK government is actually talking enough about the air quality and the problems that it comes with?
Well, no, they're not. There was an air quality strategy 2 years ago. We've heard nothing about it since. There is a decarbonisation strategy, but as I say, that doesn't mention air quality.
And you're aware of the case of the 9-year-old girl Ella, who lived in Camden in London, who lost her life in 2013 because of an asthma attack. Now, her mother successfully campaigned to change her cause of death to air pollution rather than an asthma attack. Do you think this was a turning point in terms of the conversation around air pollution and what it's really doing to human health?
I think it is a turning point, absolutely. The public found it quite hard to understand the message that pollution kills. When the statistics come out and say, 40,000 people are killed each year by pollution, people think, well, how does that happen? But the tragic death of Ella Kissi-Debrah is a highly visible, highly palpable example of how pollution directly affects people's health and kills people. Welcome, everyone. I hope you can hear me. Welcome to the final part of this webinar. So in this section, we're going to showcase the Centre's work on air quality and its health effects. And we're also delighted to be joined by Professor Jim Gauderman from University of South California. Welcome, Jim. I see you've joined. My clock says that it's 7:39 in your part of the world. So thanks for being up early, and we look forward to your presentation shortly. So in this section now, we're going to hear brief presentations from 4 presenters who work within the Centre. I'd just like to highlight before we go on to those sessions. Thanks, Claire. This is really timely, this session, because I think it's yesterday, Asthma UK British Lung Foundation published a new report, which is shown on your screen. Clear the Air. You should be able to find it on their website. At the same time, we have COP26 coming up, and with a huge focus on the environment, as you may have heard, less currently a focus on air quality and health, but we hope to change that. And finally, the Academy of Medical Sciences also have published a report on the lack of focus on COP26 of interest in air quality and health effects. So a discussion about these topics is very timely, and so I'd like to go now to our first of our 4 speakers. So it's my pleasure to introduce Dr. Hajar Hajmohammadi. She's a colleague of mine at the Centre for Primary Care at Queen Mary, and Hajar is going to present her work on air quality exposures and asthma attacks. Thanks, Hajar.
Hello. Hello and welcome to this short presentation on developing a multivariate time series regression model to understand relationship between NOx concentrations and asthma exacerbations. NOx, as you may know, is oxides of nitrogen that can iterate and inflame the airways. Our hypothesis is that greater exposure to NOx will be associated with more asthma attacks, measured here as courses of oral steroids. There are a wide range of studies in this field, which mainly focus on long-term air pollution exposure and also severe impacts of these exposures, such as mortality and hospital admission. The advantage of this study is that we studied short-term exposure and less severe effects of poor air quality on patients with asthma. The health data comes from the records of 17,000 people with asthma in East London, and the time frame of this study is 2 years, from February 2018 to January 2020. Daily NOx concentrations were extracted from 8 monitoring stations in East London, which includes both roadside and background monitoring stations. As you may know, background stations are the ones that are not dominated by a single nearby pollution source, such as road transport or construction site, while roadside monitoring stations are located within 1 to 5 meters of busy roads or busy roads near the busiest stations. Another explanatory variable in this study is daily ambient temperature that was extracted from London City Airport in East London. And as I said before, the response variable is the number of oral steroid courses prescribed for asthma-registered patients. In the right-hand side of this slide, you would see the monthly smoothed NOx concentrations in blue and number of oral steroid courses in green. As you may see, while these two time series seems to have similar trends, there are some lags between these two, and that's why we added lags of NOx concentrations to the model that is formulated in the methodology. And as you can see, it has 2 types of monitoring stations, ambient temperature and NOx concentrations plus their lags. The results of this model shows that there is a significant relationship between daily NOx measurements and asthma exacerbation needing oral steroids. From this model, roadside monitoring stations in East London are better estimators for air pollution exposure rather than background stations. This model also shows that the negative impacts of NOx exposure could be distributed over 2 weeks after that. That has 2 main components. The first one within the first week with the average of 3.8 days, and the second one with the average of 14.3 days. Another outcome of this model is a significant negative correlation between ambient temperature and asthma exacerbation, which means higher oral steroid prescriptions on colder days. Our work supports the view that air pollution, such as NOx, is an important trigger for asthma attacks in East London. And we are working on developing these studies for other types of pollution as well. Thank you for your attention.
Thanks very much, Hajar. So you're welcome to put questions in the chat, which may get answered, but preferably put them in the Q&A panel, and then we'll try to pick them up at the end after Jim's talk at the end of the session. So we can't take questions now, Hajar, but that's really helpful. Thank you very much for your presentation. Our next speaker is going to be is by video. She's recorded a video. This is Professor Melita McNary, Professor of Sports and Exercise Sciences at Swansea University, and her presentation today is called Perceptions of Air Pollution. So I hope we can set the video running now, please.
Good afternoon. I'm Melita McNary from Swansea University, and I wanted to spend a few minutes telling you about some of our work where we're looking at the potential impacts of air pollution on health in those with asthma. So we all hear a lot about air pollution. It's obviously in the news fairly often, but how many of us really stop and think what the impacts of that air pollution potentially are on our health? What if I was to tell you that air pollution is currently estimated to be responsible for 12% of the worldwide deaths, which is more than the number of people who are killed every year by HIV, TB, and road injuries combined. These are startling figures, but they don't go far enough. They don't tell us about the lives of those people that are affected by this, such as the 9-year-old Ella, who you can see on the screen at the moment, who was the first person in the UK to have air pollution listed as her cause of death following a severe asthma attack. We currently estimate that 92% of the world's population live in areas where air pollution exceeds safe limits. Yet we engage in activities within those environments. We're told simultaneously that physical activity is good for us. But if we're physically active in this polluted environment, are we potentially putting ourselves at an increased risk by breathing in those pollutants more deeply? This is what we are currently looking at. So we are working with children in the local area to assess what their physical activities are, what their air pollution exposures are, and how those two factors combine with their overall lung health. Our strategy is that if we can identify areas where children have the greatest exposures, perhaps we can then identify the behaviours which will limit those exposures without having a detrimental impact on their overall physical activity levels. So can we come up with safe ways for our children with and without asthma to engage in that physical activity that we know is so good for them? To do this, we're going to be conducting numerous studies over the next few years where we work with the children to design interventions. Having identified the best periods where they would be most receptive to an intervention, then we will work with them to identify what interventions they want in that time period, what they would actually enjoy, what they will actually engage with. Because ultimately, the best intervention is one which people will do. So our overall strategy is to identify how we can minimize air pollution exposure while maximizing opportunities to be physically active. And through this, we hope that we will be able to improve the quality of life, both now and in the future, for those with and without asthma. If you would like to contact me to discuss any of this, please do feel free. My Twitter is on the slide there, or you can contact me through my university email address. Thank you.
Thanks very much, Melita. Let's move on to our third presentation now. I'm delighted to introduce my colleague, Dr. Ros Dove. Ros is a researcher on the CHILL study, Children's Health in London and Luton, which is looking at the health impacts of introducing London's ultra-low emission zone. So please go ahead, Ros.
Thanks, Chris. I'm just going to give you a quick overview of the study rationale design and its early progress. So the Children's Health in London and Luton, or CHILL study, was designed to take advantage of the natural experiment that was going to be created by the implementation of the ultra-low emission zone, or ULEZ, in central London. This scheme is much more stringent than the previous clean air zone in London, so it's expected to produce a more significant reduction in pollutant levels, particularly those associated with diesel exhaust emissions. And early data from Transport for London suggests that this has been the case. The graph on the left of the slide is based on data from TfL, Transport for London's 10-month report, and shows a 44% drop in roadside NO2 concentrations within the ULEZ area since the announcement of the scheme. And previous studies have shown that air pollution exposure can stunt lung growth in young children. So the CHILL study was created with the primary research question of whether the implementation of the ULEZ would improve lung function and pulmonary growth trajectories in children of primary school age. The top right panel on the slide gives a very simplified overview of the study design. So CHILL is a prospective 2-arm parallel longitudinal study using an area within the boroughs of Luton and Dunstable as a comparator site to the ULEZ, giving the study a uniquely robust design. Data collection began in June 2018, and we initially recruited a cohort of over 3,000 children drawn from 85 participating schools, split roughly between the two sites. Originally, the study was planned to last for 4 years, but it's now been extended to 5, and data is currently being collected annually via 3 pathways. We are doing school visits where the children perform spirometry tests to measure their lung function. We're using caregiver questionnaires, and we'll be looking at health records. And alongside this, we'll be getting detailed air quality measurement data from the Environmental Research Group at Imperial College. So as well as allowing us to address the primary question, these data will allow us to explore a number of secondary questions, including what the impact is of the ULEZ on air quality in central London, what the impact is on respiratory health, travel behaviours, physical activity and risk of obesity in young children, and whether the ULEZ delivers measurable benefits in the perception of quality of life and reductions in healthcare use and associated costs. The lower panel of the slide shows some of the early markers of the study's progress, which are our recruitment targets, our spirometry success and attrition rates. The study was designed to achieve 90% power for detecting a difference in FEV1 growth per year between the London and Luton cohorts, but this was based on achieving at least a 70% success rate in the spirometry testing of children of this age and an attrition rate below 20%. So far, the study has met these targets. You can see on the left pie chart, I don't know if you can read the detail on the pie chart, but we did meet our recruitment target. In the middle, you can see the success rate of the spirometry testing in our baseline year was around 83% overall, and this had a positive association between school year group and the success rate. So we're expecting this rate to either be maintained or improve through the subsequent years of the study. The rate of attrition from baseline to follow-up year data collection was around 7%, and it's less certain how this rate may change over subsequent years, but it's very positive that this initial rate is well within our targets. Obviously, the study's been extremely disrupted by COVID, but importantly, none of our participating schools have dropped out. We were able to post out our questionnaires during lockdowns, and we were able to adapt our school visit protocols, which allowed some visits to go ahead in our 3rd year. And we've had good support from NIHR, who agreed to fund an extra year of data collection to compensate for the disruption over the last 18 months. So we're now in our 4th year of data collection. The study is very much back on track. So we should still be able to provide a number of important insights into the health and economic benefits of clean air zones of this type. Thank you.
That's great, Ros. Thanks very much. Very clear. And we're now on to our 4th and final presentation. This is also data from the CHILL study, but looking at a different outcome, physical activity. And I'm delighted to introduce my colleague, Dr. James Scales, who's going to present the baseline data and findings in relation to physical activity.
Thank you, Chris. So while the CHILL study investigates what health changes occur following the implementation of the ULEZ, we're also trying to explore why they occur. It's suggested that health benefits may come from the ULEZ from 2 methods. One, through improved air quality, but also through improved behavioural changes from healthier physical activity choices, such as walking to school. As such, we're running a physical activity study alongside the CHILL study to test the hypothesis that does improving air quality improve physical activity. To do this, alongside the annual lung function testing, children are offered the chance to wear a physical activity monitor. These monitors are a bit like a Fitbit, but measure exercise intensity. Claire, if you can hit next on this twice, please. Yes, that's it. Oh, back one. So as you can see on this graph, this is what the data of physical activity monitor generates. This is activity for a child throughout a week. We have time along the bottom of the graph and intensity at the top. Our primary outcome variable is moderate to vigorous activity. So that's any activity equivalent or greater to walking at 4 kilometers an hour. So we're choosing that to pick out how children commute to school. So as you can see, in these graphs, there's 4 key spikes. There's their walk to school, there's their break, there's their dinner time, and then there's their walk home. And it's changes in these spikes that we're measuring, and it's these changes that I'm presenting here today. So next again, Claire, please. If you look now on the bottom left table, you'll see graph 1. This shows that at baseline, children in London are more physically active than children in Luton. We explain this by looking at graph 2. where parents have reported how their children travel to school. So whether they travel by active travel, which is cycling, running, or walking, or using a scooter versus public transport in their car. As you can see, children in London are much more likely to use active travel methods of getting to school, whereas Luton are more likely to come via private car. We believe this may be due to the larger catchment areas in Luton, meaning larger and possibly unwalkable commutes in Luton. We're currently mapping out our participant addresses to their schools to see whether this is the case. In the final segment, we present commuting methods of the London cohort with asthma versus those without asthma. As we can see, someone with asthma is more likely to use public transport or private vehicles to get to and from school. In summary, even before the implementation of the ultra-low emission zone, children in London were very likely to engage in active travel, with the exception of children living with asthma. As such, children living with asthma may be the first to feel the impacts or benefits of the ultra-low emission zone. Thank you very much.
Fantastic, James. Very clear and very interesting. Okay, if you have questions, put them in the Q&A. It's 5:57, and so we're just a little bit behind schedule. But now it's a great pleasure to introduce my colleague Jim Gauderman. Jim is a Professor of Population and Public Health Sciences at the Keck School of Medicine at the University of Southern California. Jim is one of the world's foremost researchers in the field of air pollution and health effects. He's published seminal work in this field. He publishes regularly in the world's best journals, New England Journal of Medicine. He has been a senior figure and led the Children's Health Study in California, which is a series of longitudinal cohorts of adolescents exposed to changing air quality over time in California. And this has delivered some of the most important data around the relationship between environmental exposures and lung health and lung growth in children. I'm absolutely delighted that Jim is a co-investigator on the CHILL study, and the study is better and better informed for his participation in it. So Jim, thanks for your early start, and thanks for talking to us today about the relationship between urban air pollution and children's lung health. Thanks, Jim.
Well, thanks, Chris, for the very nice introduction, and also for the invitation to work with you on the CHILL study. It's been a real joy. All right, so I'm going to regale you here for a while about the Children's Health Study and take you on a quick tour of how the study was designed and some of the key findings. This is what downtown Los Angeles looked like back in 1948, and this is our city hall, which you can barely see. Because the air quality back then was so poor, and LA is known for its poor air quality. So what I'm going to tell you about today is the Children's Health Study, as Chris mentioned, with a focus on the health effects that we've seen due to air pollution exposure. And we had a really kind of interesting opportunity to do a natural experiment that we had not originally anticipated when we designed the CHS, and I'll tell you how we kind of exploited that to find some interesting things related to improving air quality. So the basic idea from the very beginning, and this started back in the early 1990s, was to find California communities with a range of pollution profiles, recruit children and measure their health, follow them over several years. So it was designed originally as a 10-year longitudinal study that is now in its, close to 30 years. And then concurrently measure air pollution exposure and see if changes in health are related to exposure. The focus was on outdoor air pollution and chronic health effects. So increased asthma risk, increased symptoms in those with asthma, and lung function development in the children over their teenage years. Well, this gives you a little sense of what Los Angeles looks like. We have the two largest ports of Los Angeles and Long Beach in the United States that account for about 40% of the incoming cargo for the whole country. And that then is a major source of air pollution, as well as the traffic emanating from that and the traffic from all the vehicles on our many freeways. With the prevailing kind of onshore breeze and sunlight, we get a pretty high mix of ozone, nitrogen dioxide, particulate matter in some of the inland valleys that are about 50 miles downwind of the port area. So we took advantage of that kind of exposure profile when we chose the Children's Health Study communities. So we have Long Beach, which is down by the ports. We have these inland areas, the 4 communities here, San Dimas, Upland, Marilomo, and Riverside, that are highly impacted by secondary pollution. And then we have some control communities that are in outlying areas. So as far north as Atascadero, Santa Maria, which are fairly good air quality for all of the major indicators. Set up air monitoring stations in 1994 that are still running. We have 1 per community that's been monitoring these various pollutants ever since then. And so if I just kind of capture these, this summarizes what I said already, that we have high levels of various pollutants here in the main valley area surrounding Los Angeles, low pollution levels up north, and kind of mid-range in these other places. So some of these will have high levels of ozone, low levels of other pollutants, and vice versa. So these mid ones were meant to help us try to disentangle some of the multi-pollutant effects. And as I'll show you, we haven't done very well at that. This gives you a sense for the average levels of these various pollutants. And I highlight these 5 pollutants here: nitrogen dioxide, particulates, elemental carbon, and acid. These are the 5 LA area valley communities here in red. And you can kind of see, if you look at the other graphs for the other pollutants, they're also high in those other pollutants. And so we have essentially a package of traffic related pollutants, which makes it hard for us to distinguish the independent effects of any of these. You will notice a bit different pattern for ozone. So we have been able to say something about ozone versus the other pollutants, but difficult to disentangle these. Altogether, we've studied over 11,000 children. They've come in different waves of recruitment. So the initial recruitment was 10th grade, 7th grade, and 4th grade children back in 1993. And all the cohorts have been designed to be followed through 12th grade, which is, of course, the end of high school graduation when they are about age 18. Started a new 4th grade cohort in 1996, and that was followed through graduation, and then went back to kindergarten in 2002 for the last cohort, and have since followed them through their graduation. Lots of data being collected on annual visits. So a standard questionnaire we've developed for identifying smoking, pets, et cetera, a bunch of co-exposures that they might have, as well as anthropomorphic measurements, height, weight, et cetera. And then key has been annual lung function testing. So this is a field team member taking a lung function test of one of the study children, and we're monitoring FEV1, FVC, mid-maximal expiratory flow, and peak flow, as well as a few other measures. So the first kind of good look we had at longitudinal analysis came in the early 2000s when we looked at this first 8-year cohort, what we call cohort C, followed from about age 10 in 4th grade to age 18 in 12th grade. Published in 2004, and we focused on lung function growth. This gives you a sense for the average FEV that we've observed between age 10 and age 18, girls and boys. Girls and boys have about the same FEV when they're age 10, about 2 liters. Big differences by the time they get to be age 18, boys quite a bit higher than girls, but you can see in both substantial growth over that period. So a good opportunity to try to see whether air pollution is affecting the developing lung, because there's a lot going on over the teenage years. Well, if we lay this out, here we have girls in the orange circles, boys in the blue circles. as a function of nitrogen dioxide levels in the communities. So there's 12 little vertical swatches here, one per community. So this is girls and boys from the same community, girl and boy from the same community, et cetera. You can see a trend for decreasing 8-year lung function growth with increasing nitrogen dioxide exposure. And the picture would look very similar if I showed this to you with PM 2.5 as the axis, or elemental carbon, or any of those other kind of package of pollutants. Statistically significant, and a deficit estimated of about 100 mLs in FEV over the complete range of low to high exposure. So remember, the increase was about 1,300 mLs in girls, about 2,400 in boys. So 100 is a pretty substantial deficit in that lung function growth. We took a look at what lung function looked like at age 18 and used clinically important cutoff of FEV below 80% of normal, adjusted for anthropomorphic measures, age, sex, et cetera. And you can see here that these 5 LA communities with high levels of pollution, and again, I could show this to you with NO2 or any of the other package of pollutants down here, it would look the same, have increased proportions of children with abnormally low lung function as they transition into adulthood. So again, this is at age 18. And in some of these communities, as much as close to 10% of the kids had what we would call abnormally low lung function as they transition into adulthood. And again, as I mentioned, this is the plots that you see with all of those pollutants. Not much going on with ozone related to percent predicted. Very similar patterns with all of the other pollutants. Why do we care? Well, we care because by the time children reach age 18, particularly females, but even boys, they're pretty much done with lung development. Boys develop until their early 20s, but then we all kind of flatten out in terms of our lung function in our 20s, and then there's the slow decline that we all have as we get older. So imagine if you're starting down here on the lower curve relative to maybe where you could be in the upper curve, and that if that trajectory continues throughout life, then we get out here to the upper end where we know that low lung function is related to a variety of really important health effects. And so, the concern is if you start low and continue low, that as these children get to be older and older, they may be at risk for some really important adult health effects. What about asthma? Well, of course, asthma is going to be very important as well. I'm not going to talk a lot about the direct effect between air pollution and asthma. I'll talk a little bit about asthma-related symptoms, but there's a bunch of studies out there that have also linked air pollution to asthma risk, and a nice paper in 2017 that summarizes that, and I'm not going to attempt to cover that. What we have looked at, though, is bronchitic symptoms, and this is an early paper we had looking at non-asthmatics down here in the orange triangles, asthmatics in the red dots, and you can see that within the kids that have asthma, there's a pretty strong association between the level of PM that they're breathing and their prevalence of bronchitic symptoms, suggesting that asthmatics are a susceptible group to the effects of air pollution. Not only do they have much higher bronchitic symptoms, as you would expect, all the red dots are higher than the orange triangles, but this trend is the concerning bit, that it increases with exposure to air pollution. Well, I've already kind of made a point of this. The primary source of exposure in Southern California is traffic and the ports, which affect the traffic as well. So we really wanted to kind of follow up on these community level associations that we've been seeing and the links with NO2 and elemental carbon particulates, which we know have their primary sources in exhaust, by delving a little bit more deeply into the relationships with traffic. So we looked within our communities. This is one of our inland communities, Riverside, mapped the locations of where our children live. These are the red dots, and then how far they were from major freeways. So Riverside is kind of crossed by a couple major freeways. Some of these kids live virtually right next to the freeway, others quite a bit further away. So it gives us an opportunity to look within communities and try to see whether we can see some gradients in health that are related to how close children live to these busy roadways. So if you look at prevalence of asthma, for example, and this is actually looking at asthma risk, we saw a pretty strong association between distance to a major road and the risk of asthma, about 18% for those that live very close to the major roads, dropping down to about 7 or 8% for children at least 500 meters from a busy road. So kind of the first sign that we had that busy roads were pretty important for determining respiratory health. In this work, looking at lung function, we leveraged, by this time, we now had 2 cohorts that had 8 years of follow-up data in lung function from 4th grade to 12th grade, what we call cohorts C and D, and a total sample size that's close to 3,800. And if we looked across our 12 study communities, interestingly, we had within 6 of the communities a pretty substantial number of children that lived within 500 meters of a busy road. In the other communities, not so much. So we didn't have a lot of ability in these communities to say much about busy roads. But the nice thing was in these 6 where we did have children close to roads, some of them were in our less polluted communities up north, and then some were in our polluted communities. So it gave us the ability to look at the effect of a busy road on local health effects against the backdrop of clean air and against the backdrop of more polluted air. And so this will demonstrate this. So thinking about those 2 dimensions, low background particulate matter and far from a freeway, this would be the lowest exposure group. So up north and far from the main highway up there. If we take those as our baseline and call them, the best lung function growth over 8 years, then we can distinguish them from individuals that live in that clean area, but they're close to the freeway. And across the communities, and using all the data to estimate this, there was about a 4% drop in 8-year lung function growth, just due to living close to a freeway. If we focus on the polluted community, but being far from a freeway, so now this is the background pollution level that we've kind of already investigated, we again saw that was an important exposure, about a 5.5% drop in 8-year lung function. And then interestingly, for those children that are unlucky enough to live in a polluted area and live close to a freeway, essentially the combined effects of both were what we observed. So close to a 9.5% decline in 8-year lung function growth. So, throughout all this, we've been trying to make sure that the work we do gets translated into something important. And cynics might say, you spend a lot of money to show air pollution is bad for you. We've kind of known this for the last 50 or 60 years, and kids shouldn't play near streets. But how do we actually use this information? Well, fortunately, there was a lot of emphasis in air pollution by this time. Our work and a lot of other work that's been ongoing, not only in the United States, but really in Europe as well, and other places, was instrumental in some of the standard setting by our US Environmental Protection Agency. We had some local interest in some of the main freeways. This is the main freeway emanating from the ports, and a lot of testimony by us and others that had a stake in this, trying to affect things like, should they double deck the freeway? Should they expand the freeway into local neighborhoods, et cetera? And just recently, the EPA nixed a plan that was going to expand the lower 710 freeway down by the port and impact some of the local communities down there. So this has been a multi-year battle that the communities down there have been fighting. And then school siting has been very important. So here's an elementary school sitting right next to one of the major freeways. That, of course, is a concern. And after we published the pollution and traffic paper that I just showed you, there was a writer at the LA Times that highlighted that. And soon after that, the school board acted to limit new schools being built near freeways. Plus, there were during this time, a whole bunch of other policies that have been put in place related to electrifying the ships while they're sitting in the ports and having their loads unloaded, cleaner fuel, newer, cleaner diesel engines that affect on-road, off-road, and stationary sources. I'm not going to go through this in any detail, but you can say it really spans a broad time between the late 90s, early 2000s, and affecting a number of different kinds of axes of where pollution happens. But a key question is, does cleaning the air really affect children's respiratory health? So we took advantage of all of these policies. And another key was that we had this third cohort sitting in the wings, and we were able to collect lung function data on them. We didn't have as much funding to do lung function testing, so we had to focus in a narrower age range, but it overlapped the age range, and this is from 5th grade to 9th grade, so about age 11 up to age 15. And we had that same age range for our other two cohorts. And in between here, we had a lot of these policies that serve to potentially improve air quality. So we wanted to see, one, did air quality really improve in our polluted communities over this time? And two, could we detect any health effects related to those changes? So we focused on the 5 communities that I've pointed out a few times that are in these more in the valley area of Los Angeles, because they are the most polluted communities. And over this time, we had more traffic, increases in economic activity, increases in population, increases in port activity. But despite that, and because of all these policies that were put in place, the air quality actually improved by quite a bit. So for example, NO2 levels in Upland, one of our more polluted communities, dropped from about 40 parts per billion down to about 20 parts per billion on average over that time period. And you can see pretty dramatic decreases in air pollution in all 5 of these kind of valley communities that we've got. Interestingly, not quite as dramatic for ozone, but these policies were really targeted at the kinds of sources of these pollutants here. What about lung function? Well, it turns out that if we looked at the 3 cohorts in each of these communities, so if we look at the purple here, this is one of these communities I pointed out. This is cohort C, breathing about 40 parts per billion over that 4-year period from 5th grade to 9th grade. Cohort D and cohort E, the one breathing lower pollution levels. And you can see the 8-year lung function growth, the 4-year lung function growth was quite a bit higher in the latter cohort, breathing the better air. And we saw the same trend happening in each of the 5 communities. Really strong kind of linear trends in most of these situations. So on average, if you kind of pool this, we estimated that a 14 parts per billion decrease in NO2 was associated with about a 91 milliliter increase in FEV1 growth over that 4-year period. And again, we saw this association in all 5 towns. So remember this plot I showed you earlier of the proportion of children with abnormally low lung function at age 18. And it was about 2 to 4% in some of our cleanest communities. Well, we came back and looked at that again in cohorts C, D, and E at age 18. And it was about 8% in cohort C, a little bit better in cohort D, and down to about 3.5% in cohort E. So we'd like this to be down kind of where it was for the clean communities, but it's certainly an improvement over what we had back in the earlier cohorts that we looked at. We also looked at bronchitic symptoms and how that was affected by air quality improvements, and we saw similar associations. So we were able to study more communities here because it was questionnaire based and we didn't need to have lung function measurements. In children with asthma, pretty strong improvements in bronchitic symptoms with decreasing NO2, and even for children without asthma, similar improvements. So to summarize, we've seen air pollution associated with chronic health effects. Children in general are susceptible. We've seen these lung function effects in asthmatics, non-asthmatics, and we've looked carefully at a variety of confounding variables. And I didn't show you things here related to that, but they're in all of these papers. No evidence of confounding by other co-pollutants, environmental smoke, etc. We've seen these respiratory effects most closely linked with this package of traffic-related pollutants. And as I mentioned, it's been difficult to identify the independent or specific effects of these. No real evidence of threshold effects. We see pretty linear associations, not really a bend in the curve saying, you know, you've reached the point of okay air quality. So, you know, suggestion that you know, as good as you can get it, it improves children's health. And regional local exposures are definitely important. So again, reductions in air pollution have been associated with measurable improvements in children's health. A variety of papers that have come out showing that the same is true for adults. And, you know, it's important now that we don't get complacent. So our national air quality standards are not yet achieved for particulates and ozone in Southern California. We've continued to see more cars and trucks, although, as Chris pointed out earlier, what you've seen in England related to the pandemic has certainly been true here as well. So some of the traffic counts have gone way down with the pandemic. But I'm sure they'll come back once life gets back to normal. So although future reductions in pollution may be difficult, hard work to improve air quality certainly pays off. So I'll end there and thank you for attending, and thanks again to Chris for inviting me.
Thanks, Jim. Absolutely brilliant, and you know, such important work, and you know, so clear and so thorough, so robust, and with such important findings. And you know, you've translated them into really important policy decisions. So you know, I'm sure that we'll take a collective hat off to you for this fantastic program of work. We've got some time for questions. I know you'll want to get your breakfast, but oh,
I'm fine. Already ate, so.
So I got a question from Kevin saying, sorry if I missed this, can the reduced lung function development in children caused by pollution be salvaged in later life by moving to a cleaner environment?
Yeah, that's a really good question. So, you know, I think during the growth period, there may be a little bit of potential for that to happen. There was a study we did midway through that I didn't mention where we did have obviously attrition from our cohort, which always happens in cohort studies. And some of these children move to much cleaner areas, as you know, far as up in Washington State or what have you. So we did put the field team on an airplane and we followed up about 200 of those kids and then tried to do some lung function testing and look at the air quality in the places they moved. And we saw an association between moving to a cleaner place somewhere during their teen years and improved lung function relative to their old friends that stayed in the Southern California area. So some evidence that at least during the growth period, there might be some ability to gain back some lost lung function. After adulthood hits, I think that the chances are much less, and we don't really have data in our kids going much beyond age 18 to be able to look at that. But you know, I think the general sense is once the lung is done growing, it's done, and there's not really the ability to gain back lung function.
That's an important message. Please do put your questions. So Stan, yeah, I was going to ask you if you had a question, but you've given a comment. Excellent presentation on a career worth of work. with significant impact. Stan, if you want to ask a question, then please add one as well. I can't see hands up. I'm going to ask a question. It's often said that the effects of pollution are greater in those living in more disadvantaged communities. Do any of your analyses support that?
Yeah, they actually do. So, you know, after all of these kind of primary findings came out, we have spent some time looking at subgroups. We have predominantly non-Hispanic white and Hispanic white children that live in our area. About 45% of our sample is non-Hispanic white, about 45% Hispanic white, and very small handful of Asian and African Americans. So we took advantage of that to kind of look at exposure differences and also health differences. And we do have a paper reporting that on average, the Hispanic white children tend to live significantly closer to busy roads, and that the effects on asthma risk are stronger, even, you know, for the same kind of exposure in Hispanic whites compared to non-Hispanic whites. So that, you know, that is a real concern around here, especially on the exposure side, because we know that a lot of the siting of roads and other sources is placed in economically disadvantaged areas, and that puts a burden on those subgroups for sure.
And the corollary, do disadvantaged children benefit disproportionately from interventions to improve air quality? Do they get a benefit?
Yeah, that's a good question that actually we haven't looked at. So it would be really interesting to kind of go back and look more carefully at some of our improved air quality, improved health, and see whether we can pick that up. That's a great suggestion. We have not done that.
Good. Any more questions coming through?
I see Andy Bush has a hand raised, it looks like.
Andy, fire away.
Yes, Jim, thanks for a fantastic talk, and what a fantastic body of work over so many decades and what you've achieved. I think it's really important to ram home the developmental perspective. People might say these are only little tiddly changes in childhood lung function, who cares? The VESPO data in the New England Journal of Medicine shows that if you don't hit your plateau of lung function at 20 to 25, you've got a 26% chance of COPD later on. And the Augusti Lancet Respiratory Medicine paper shows that if you don't hit that plateau, you have early onset of all-cause cardiovascular, metabolic morbidity and mortality. So although the signs may not look that dramatic, they sure as heck are extraordinarily dramatic for what is going to happen later on if the sort of effective stuff that you've championed over so many decades doesn't happen.
Well, thank you, Andy. Definitely important note, and thanks for the kind words.
There's a question from Stan. Is there an additive effect of allergic airway inflammation with pollution?
That is a good question. I'm trying to think back to whether we've addressed that directly, and I don't recall that we have. So I'm not sure I can comment on that based on our data, at least.
Okay.
Yeah, sorry about that.
And another question from Kevin. Any thoughts on the use of indoor playgrounds or promoting kids to play indoors in the gym in areas with high pollution? Sounds a horrifying suggestion.
Yeah, I mean, there's a trade-off, right? Because you want kids to get outside, and there's a whole bunch of other things that are good about being outside, increasing your vitamin D levels from, sunshine exposure, et cetera. Certainly in those areas where we have schools and the play area backs right up against the freeway, we have counseled some of those schools to try to impact where the kids play, and have advised them to, as much as possible, build their play sets or, swing sets, that kind of thing, more towards the buildings and less towards the busy roads. But kids, it's going to be impossible to dictate where they play, and they're going to go wherever the ball fields are and things like that. So it really comes down, in our view, more towards city planning and local decisions about where parks and schools are sited. And that's why I think, some of these battles that we've provided scientific data to the local groups, and they can then fight those battles has been really important and gratifying for us to kind of see the science in action.
Great. One question. Has the EPA, Environmental Protection Agency, been hamstrung by the Trump administration? And is there any prospect of recovery?
Yes, and I hope so. There was definitely a relaxation in standard settings, and a sense that the science was not paid very close attention during the Trump era. And, it's going to take a little while to unwind, but hopefully under Biden's administration, that's going to move in a different direction. And we're desperately hoping, Trump does not emerge in 2024.
Perish the thought.
Yes.
Are there any questions relating to the talks that people want to raise? I think the talks are great, but you've eclipsed them, Jim, with your presentation.
Well, didn't try to do that because I really enjoyed the earlier talks as well. So, and especially interested to see, how things are going in your study, Chris.
Well, it's been a bit of an uphill struggle with coronavirus slap bang in the middle of it, but it's a fantastic team, and the kids are as keen as ever to do the study. So it's hopefully we'll deliver on it.
Are you guys back to full in-person learning kinds? Yeah.
The school visits are going ahead. Schools are happy to see us. We're vaccinated. We do lateral flow tests. We go to rooms, do the stuff in spirometry in large rooms with the windows open with CO2 monitors, and that works well. So we're back doing our assessments. So that's a relief for everyone.
That's good to hear. Yeah. Well, congratulations on getting through all that.
Yeah, it's been hard. I mean, it's been hard for the team. I would say, particularly, it's very frustrating. But we should draw to a close now. I'm sure everyone will join me in thanking you, thanking all the presenters in this session, and a really great discussion. But especially Jim, it's been a huge pleasure, and one of the benefits of technology to be able to hear you in the conference today, and you've really allowed us to end on a fantastic, inspiring high note, and I'm sure we'll go back to our research projects with particular enthusiasm as a result of this. But we're delighted, and I can't thank you enough for joining us today.
Well, it's mutual, Chris. So thank you so much for the invitation. Thanks to everybody for attending, and it's really, again, great working with you and your team, and I'm really excited to see, how your study comes to fruition and help it in any way that I can. So
that's great. Thanks. Now, do I need to hand over back to Aziz for a final roundup, or are we done here?
No, I mean, I think you can close, Chris. But I mean, can I just echo Jim? Absolutely fantastic, and as Andy and others have said, I mean, a lifetime of work that's been just absolutely transformational. I'm so glad that we've been able to cover this on the eve of a really important conference in Scotland. So thanks so much for doing this. So Chris, you can close. I mean, happy for you to do that.
Thanks, Aziz.
Yeah, to close, I would say that the webinar's been fantastic. Really good presentations from everyone. But broadly, the annual scientific meeting that we've had prior to this webinar has been a great success. It's been fantastic to see so many people join, and so much enthusiasm and commitment and positivity about the centre, and a lot of great suggestions as to take the work forward in the coming years. One of the best things I think, was to hear people to say that it's great to meet, and we're looking forward to seeing each other face to face. And I'm delighted to say the next annual scientific meeting in Leeds, definitely, without a shadow of a doubt, we will be face to face. So thanks to Susan, Claire, Wendy, and the team, Hilary, for organising it. Thanks again to our fantastic International Advisory Board. It's always a pleasure to hear you, and you're always so supportive and generate such enthusiasm for us. So with that, I think with Aziz, we'll say thanks again to everyone, and we look forward to continuing our work together.
Thanks so much, all. See you soon. Take care.
Thanks, Jim.
Thanks, everybody. Thanks, Chris.
Thanks,
Aziz.
thanks.
Bye.